Hi, I'm Sam Masri, and today I'm going to be going over the diphtheria vaccine. So first I'm going to just cover the disease as briefly as I can, and then I'll move on to talk about the vaccine. So the infectious agent for the diphtheria disease is Corynebacterium diphtheriae. It's an aerobic gram-positive bacillus, and there are two main strains. There's the toxigenic and non-toxigenic strains, and the toxigenic strains are generally the ones that cause disease, especially severe disease. And interestingly, the toxin gene is actually usually carried by lysogenic bacteriophage. So the toxigenic diphtheria strains are generally infected, produce the toxin when they're infected by that lysogenic bacteriophage. Um, and the bacteria was first observed in the 1880s by Edwin Klebs and Leffler. As far as the actual disease, there are two main types of diphtheria. There's respiratory and cutaneous diphtheria, with respiratory being generally the more serious one. Signs and symptoms include weakness, sore throat, fever, and swollen lymph nodes, which produce that bull neck, um, which is one of the markers for diphtheria, which is pictured in one of those pictures. It can also lead to pseudomembrane formation, which is another hallmark of diphtheria, which is actually how it gets its name, from like the leathery hide, which is what diphthera meant. So that pseudomembrane formation occurs from uh, cellular death from the toxin which the bacteria produces. Uh, and that can cause difficulty swallowing and breathing, and it can be very serious. In fact, diphtheria was used to be referred to as the strangler, um, just because of that. And cutaneous diphtheria causes sores and ulcers, as you can see in that picture down there. And the pathogenesis of diphtheria, the bacteria colonizes the skin or the upper respiratory tract, and it secretes an endotoxin, which I described previously, and that leads to cell death and can lead to the pseudomembrane formation. And then when the toxin it can be absorbed and further absorbed and like to distant organs, and can affect distant organs, and that can lead to a host of other problems, including paralysis, kidney failure, and congestive heart failure. In fact, most of the deaths actually occur from congestive heart failure. It's, diphtheria is transmitted through respiratory droplets, and treatment involves antitoxin and antibiotics, but it's far more effective just to prevent getting the disease through vaccination. Because even with treatment, the mortality rate is something around 10%, which is uh, very high. So as far as the vaccine components include the diphtheria toxin. It's toxoid based. So the toxin is collected from cultured bacteria, and then it's inactivated through formaldehyde and heat, and which makes it a toxoid. Which the toxoid is something that can be recognized by the immune system, but it doesn't cause the debilitating effects of the toxin. The vaccine contains aluminum adjuvant, and is administered with tetanus and pertussis, uh, most commonly. So there are variations on that. There's the DTap, the TDAP, and TD. The lowercase letters just indicate a smaller dose of that particular component. So the lowercase d's indicate smaller percent of the smaller dose of the diphtheria component. And different DTaps may contain various antibiotics such as streptomycin, neomycin, and polymyxin B. Um, so as far as the vaccine schedule is concerned, it's administered IM, and the first doses are recommended in infants during infancy, and that for infancy and childhood, it's supposed to be the DTap that is used. And so generally there's 3 primary doses occurring at months 2, 4, and 6. And then after these 3 primary doses during infancy, there's a booster dose at around 15 to 18 months. And then there's another booster that's recommended before entering school if the previous 4 doses were given before the 4th birthday. So between 4 and 6, another dose is recommended. And there's some flexibility with this schedule, but this is the recommended one. And DT may be used if there's contraindication for pertussis. So that just removes the pertussis component. It's not very common, but then after childhood, it's recommended that you get another dose between ages 11 and 18, but this would be the Tdap or the TD vaccine. And then after that booster during adolescence, subsequent booster doses are of Tdap or usually TD are recommended every 10 years or so. And especially if you're for older adults who are going to have who have contact with infants, it's recommended to get the Tdap just to get that pertussis component. And then 1 dose of Tdap is often recommended for pregnant women, and it's an off-label recommendation, but the point of that is to reduce the stress of the burden of the pertussis component on the infant as much as possible. And this graph down here shows some evidence for some basis for that recommendation. So there are different types and brands of the DTP vaccines. So for the DTap, there's various different combinations, and so there's the regular DTap, just those 3 components, and then there's the DTap Hep B with Hep B and IPV components. Then there's the DTap with IPV and Hib components. Then there's the DTap with IPV, Hib, and Hep B, and then there's the DTap with just the IPV component. And so all of this is to just kind of condense that, just the recommended vaccine regimen for infants and children, just to condense that a little bit. And then there's the Tdap and then the TD, which are used after 6 years of age, so from people 10 years and older. As far as vaccine safety is concerned, it's just generally mostly local reactions, like other vaccines, redness, pain, swelling, which are usually more frequent in later doses. Mild reactions are common with headache, fatigue, mild fever. And then moderate to severe systemic reactions can occur. They're extremely rare, generally fewer than 1 in 10,000 people. Those would include a fever of 105 degrees or higher, febrile seizures, and hypotonic or hyporesponsive episodes. Then Arthus-type reactions are also extremely rare, but they can occur. Localized inflammatory response, hypersensitivity response, but it's extremely rare. And then there's no causal relationship established between the vaccine and diseases such as encephalitis, autism, multiple sclerosis, Guillain-Barré syndrome, and palsy and other such diseases. So in regard to the history of the vaccine, it was first developed by Gaston Raymond in Paris. He took the toxoid, exposed it to heat and formaldehyde, which inactivated it to produce, well, he took the toxin and inactivated to produce the toxoid. And the first major trials were conducted in Ontario in 1925, and they did the 3-dose trials, which were extremely effective. And so it became first widespread in Canada. The U.S. and Britain were reluctant to adopt its use until about the mid-1930s. The U.S. started really adopting it, and then Britain in the 1940s. And a lot of that had to do with outbreaks in World War II, significant outbreaks of diphtheria. And so over time, by the 1940s, it started really, hesitancy kind of dropped, and it started being adopted pretty widespread. So the effects of the vaccine have been it's been one of the most successful vaccines that as far as just reducing really bad disease. It used to be one of the major causes of childhood deaths in the U.S. and I mean in other places where it was prevalent as well. In the 1920s, there was 100,000 to 200,000 annual cases with 15,000 deaths. So it was a very serious disease. And then contrast that to today, after vaccines, 2 cases were reported in the U.S. between 2004 and 2017. And it still occurs in under-vaccinated regions of the world. So that's one thing that can be improved, is increasing vaccine accessibility. Here you can see in these 2 pictures just how the vaccine has an effect on the incidence of diphtheria disease. Here's when the bottom one shows when the vaccine was introduced. The top one shows actually the Soviet Union. An epidemic broke out in the 90s because of the lack of vaccinations. So that was kind of a serious thing. And this is another chart that shows the efficacy of the vaccines. And then this shows the vaccine coverage in 1980 around the globe. You can see how, like, Russia didn't even have any until the 90s when they had that big epidemic. This shows the coverage today. So there's still some work to be done, but overall, it's improving. Thank you.